Welcome to the Saving Lives podcast. I'm Eddie Joe. Let's go ahead and just talk about this mustache, because if you're watching this on video as opposed to listening to it on audio just in your car or whatnot, you will notice that I got a big, amazing mustache in my face. And I've been growing out a mustache every year, every November for about 12 years now for the Movember Foundation, because I think it's of utmost importance to go ahead and work with this foundation for initiatives of men's health, prostate cancer, mental health, etc., etc. So if you want to contribute and donate, there will be a link below. On today's podcast episode, I'm going to be discussing something that's honestly only relevant for those of us who take care of patients who undergo cardiac surgery. If you're somebody who works in the medical ICU or trauma ICU, then this will not pertain to you. The title of the article that I'm going to be discussing today is Atrial Appendage Closure is Associated with Increased Risk for Postoperative Atrial Fibrillation. It was published in the Journal of Cardiothorac Surgery in October of 2024. Today's November 3rd of 2024 for historical context. And as always, I recommend you read these data for yourself. This article is open access, so you can critique it as you choose. And as always, hat tip to the authors for their wonderful work. A quick plug for my book, the Vasopressor Inotrope Handbook. There are numerous ways to purchase it. You can purchase it on my Shopify account, where you will get it directly from me. As a matter of fact, this one's going out this afternoon, and I will happily sign it and personalize it for you. If you want it a little bit faster or without going through my Shopify account, you could also purchase it on Amazon. But whichever way you get it, thank you so much for your support, and I appreciate the feedback on this. So thank you for that. Starting off with a little bit of background on this topic. Patients who undergo cardiac surgery have a known complication, which is postoperative atrial fibrillation. Depending on what data you read, the incidence of this could be 20 to 40%. Some data say it's 30%. Some data say it's as high as 50%. Generally speaking, I like to tell my patients it's about 33%. Therefore, 1 in 3 patients will develop atrial fibrillation after cardiac surgery. A procedure that is now being done in a lot of patients who undergo cardiac surgery is left atrial appendage closure. And what this does is basically go ahead and clip that left atrial appendage, and that prevents blood clots from forming and potentially causing strokes if the patient were to go on AFib. Now, this procedure is often recommended in patients who do have atrial fibrillation underlying, since, they're already going to go in there, and it may lower long-term stroke risks in these patients. However, this procedure is being done also in patients who do not have atrial fibrillation, since we know that as we age, the chances of developing atrial fibrillation increases, and therefore it could prevent strokes in the future. But it's less clear of what the benefits are to this. So what these authors intend to do in this study was to determine whether the closure in this device in patients without a history of atrial fibrillation is it beneficial for these patients, or is it potentially harmful by increasing the risk of postoperative atrial fibrillation? So they looked at different outcomes, such as the rate of postoperative AFib, postoperative hospital stay, 1-year mortality, 30-day readmission, as well as the incidence of stroke within 1 year post-surgery. That's a key factor in this study, where they only followed the patients for 1 year, because again, this is a database study. What they did from an overview perspective, as I can't speak today, is that they analyzed data from 2,059 adults who underwent cardiac surgery, which included cabbages, aortic valve replacement, and mitral valve replacement between 2018 and 2021. So of all these patients, 169 patients received the actual closure device, while the remaining 1,890 did not. And all the patients in the study, and this is important to note, all the patients in the study did not have atrial fibrillation before this actual surgery. In order to make these groups comparable, they used propensity matching, and they created balanced groups with comparable baseline characteristics, and they were able to match the cohorts with 162 patients who had the closure device placed and 162 who did not. And this allows us to, or not us, because I didn't do anything, but this allows the researchers to compare the groups a little bit more uniformly. So here are the key findings. First, they found that there was an increased risk when using this closure device of new-onset postoperative atrial fibrillation. which is not the intention of this, right? You want to not create more AFib in these patients. And they found that it occurred in 41.4% of patients who had the closure device compared to 25.3% of patients who did not, which means that the risk increased by 2.18 times higher for developing postoperative atrial fibrillation compared to not having the closure device placed. Now, anytime that a patient does develop atrial fibrillation in the post-op period, there is a known increased length of stay, because we have to figure it out. Do we go ahead and convert them? What drug treatment do we give them? Do we have to shock them out of it? All these decisions take a little bit of time. And what they found here, and no surprise, is that the patients who did develop atrial fibrillation, or the patients who did have the closure device placed, they had a longer post-operative length of stay in the hospital, where it was 142 hours compared to 120 hours for the group that did not have the closure device placed. So these data suggest that the increased incidence of postoperative atrial fibrillation and therefore the associated complications of this may contribute to these prolonged recovery times. Other key findings include the fact that there was no significant impact on the other outcomes that they were looking at. And this means 1-year mortality, 30-day readmission rates, the incidence of stroke within 1 year post-surgery, because again, this is how long that they follow these patients for. And this suggests that patients without underlying atrial fibrillation, this procedure may not provide the anticipated protective benefits against stroke or mortality. But my assessment on this is that, you're only following these patients for a year. So that you might need a longer timetable to follow these patients up, but I can't speak for what processes these institutions have to follow patients up long-term to be able to tease out these effects. All in all, the implications of the study is that it challenges the fact that many cardiac surgeons and many cardiac surgery programs are actually using these closure devices in patients without underlying atrial fibrillation. And while it is known that these closure devices do function in reducing stroke risks in patients with underlying AFib, in these patients we might actually be creating more AFib, which is a balance that we need to really have a serious conversation about and think about how we're going to move forward. So the question really that's raised by the study as to whether this increased risk of postoperative atrial fibrillation outweighs the potential benefits, we don't quite know. I would like to know what you think that we should do moving forward for these patients. Should we keep on using these closure devices, thinking that these patients are solely developing this atrial fibrillation because the cardiac surgeon is manipulating the heart and everything that goes along with the tissues and the changes in anatomy of the heart itself? I really don't know. I'm look forward to additional data on this. In other words, more than 169 patients, but this is something that we should definitely keep an eye on and use registry data at our respective institutions to compare these patient groups to possibly tease out whether we are causing harm to these patients, because again, we do not want to cause harm to absolutely anybody. So again, I'd like to know what you think. Should we continue to use these devices in patients who do not have a history of atrial fibrillation? Let me know what you think in the comment section below. And again, thank you everybody for your support. Thank you for supporting the Movember Foundation, because you're gonna have to look at me, even though I don't show my face that often, but you are gonna have to put up with this wonderful, wonderful mustache. And thank you for supporting the Vasopressor Inotrope Handbook, because I really appreciate it. It's been a lot of fun, and I'm working on some other projects now that are pretty exciting. So I hope you guys enjoyed those too. Thank you so much. Have a great day. Bye.